Josh Hennig back here and Hanging with Hennig on 97.3 ESPN. It is time for the Ivy Rehab Injury Report with over 80 locations around South Jersey offering best-in-class outpatient physical therapy. I can say that because they were my physical therapists. That's what we have them on each and every week here on 97.3 ESPN. Of course, today we got a couple of interesting injuries to get into, and joining us to talk more about them. Now, I'm going to fully admit, I said this before I went to break, and I'll say it again. Vinny sent me a pronunciation guide, and I got to tell you, Vinny, you confused the you-know-what out of me. So I'm going to try to think what I think the pronunciation is.
You can just call me Vinny. We're fine. We're good.
So Ceasrine.
Yes, exactly.
Okay.
It only took my wife about 8 years to figure out how to say it. So we're good.
Oh, all right. Well, see, that's what I thought it was. But then you said the email this morning, and you confused me. So
I'm sorry about that. Yeah.
But listen, we do have some interesting injuries to get to with some guys because, for those who don't listen all the time here on 97.3 ESPN, we do the injury report every single week, and it's usually somebody in the news. And for the Phillies who desperately need pitching, that's why they acquired Caleb Killian. And now he is on the 15-day injured list with a left oblique strain. Now, there is no official timeline for when he is returning, but reports say that he is going to be out the rest of the month of August. So, Vinny, talk to us about, for a position that is so heavily dependent on mechanics and repeating the same motion again and again. Why does it seem like pitchers get these oblique injuries and it puts them so completely out of action?
Well, I'm happy we're talking about this because it's something we also got to keep an eye on down the road when he returns. We're going to talk about why that is, but they're calling it a moderate oblique strain. So typically if it's on the glove side, it's going to be an internal oblique. So we have an internal and external oblique on each side of our abdominals. And that muscle is the link between the lower half and the torso. And again, we can't rush back once he's done with rehab. And before delving into the injury, I think we should talk a little bit about how everything is linked between the lower half and the top half in pitchers. And again, we treat a lot of overhead throwers in our clinic. So this is kind of right up our alley. We'll talk a lot about this, but we see some oblique injuries that can lead to further issues, which we'll talk about. So let's go over quickly. So the pitching is by far the most dynamic athletic activity. The ability to throw efficiently and reduce risk of injury. It's an interdependence of muscular and neuromuscular between all body segments from the foot all the way up to the hand. In order to throw properly, we've got to be able to transfer those forces from the lower extremities to what we call the kinetic chain up until the arm through the act of throwing and also during deceleration. All right, so we've even had a lot of issues where we get kids with shoulder and elbow issues and we go in and we look and the problems are actually coming from downstream. So the core basically transfer forces from the lower half of the arm to the trunk. The internal oblique on the glove side links the pelvis and hips to the upper body to transfer those forces. So it basically acts as a bridge in order to channel energy from the lower half to the upper half. So if there's a couple things that can happen. So in order for that internal oblique muscle on the glove side to work efficiently, we have to get what we call the serape effect, which is a separation between your pelvis and your trunk. So when we throw the pitchers, once their foot lands, the pelvis has to open first and the trunk has to follow. That separation, that will actually lengthen the internal oblique and then let it produce efficiently. So we're taking out to maximum amount of stretch and then it's going to be able to rebound and then throw and then aid to our throwing because it's going to rotate your trunk and flex you forward. So any problems along that whole link of chain can put that internal oblique on, cause it to have an increased risk of injury. But there's two things I want to note about Caleb. So I went back and did a little research. So apparently he had an injury in the spring of 2024 for his right shoulder, where he had some cuff issues, and he missed half the season. So that's one thing. And then since joining the Phillies, I also noticed another thing. So he's had 4 appearances in 6 days. And what I did was I looked at his last 20 appearances, and I broke them down to 4 appearance blocks. And in each of those, his average rest days were 10. All right. So he's went from 10 days rest between 4 appearances to 6 since he joined the Phillies. So, I mean, again, I don't know. I've never seen it before. But again, if there is any fatigue related, that's going to basically cause some issues because it's going to decrease that trunk control. So once you start to fatigue and you miss that link between your pelvis opening and your trunk staying back, it puts that internal oblique at a major disadvantage. So right now, again, when he starts to return to throwing, they're really going to have to keep an eye on his mechanics that there's no compensatory changes. But so that's why that muscle group is very can get injured very easily. Anytime there's any kind of link between the lower and the upper half. And the typical throwing mechanic deficiency we see, especially in younger throwers, is opening the trunk early, or what we call early trunk rotation. That, again, it doesn't allow you to get that stretching of that internal oblique, which then allows it to work efficiently. So whether there might have been some fatigue involved, maybe didn't get the proper hip separation, it's kind of hard to say.
So then what are like the checkpoints that someone would need to go through in order to actually return from this, to be able to say, hey, now you can go out there and do what you were doing before the injury? Right.
So again, I was reading through and it looks like they listed them as a moderate internal oblique strain, which usually means typically about 3 to 6 weeks. So I think the key here is, in order for him to return to throwing, if we had someone come in like that, there'd be a couple of things. We need them to be a basic twist and bend without any pain. We would do a manual muscle test where we put them in a position where that muscle is firing. It would have to be equal to the other side and pain-free. And then we would return to throwing. But here's my thing. If we get a kid in that comes in, or any college or professional, and they've got that strain, the early stages in rehab, I'm making sure they're doing everything and they've got all the things that they need in order to get that trunk separation. So why does someone open up their trunk early? Well, functionally, if you don't have enough shoulder external rotation where you can't get your arm back, you're going to open your trunk early. If you don't have enough hip internal rotation, that backside hip, the trail leg, if that can't rotate internally, you're not going to be able to separate your pelvis from your hip. And then again, decrease in trunk rotation. So for me, I'm looking at, okay, we're going to calm that down at internal oblique. But in the meantime, I want to make sure you got those other 3 entities ready to roll. So when it's time to return to throwing, then we know you've got everything that you need. And again, once he returns to throwing, they're going to have to really keep an eye on his mechanics, because what might happen is, again, our body will tend to compensate. So if we know that we get to that stretch position where that internal oblique's getting stretched, subconsciously, if you're like, you know what, I'm not going to allow it to stretch too much because I don't want to get to a point of injury, then I might open my trunk early. Well, that's fine. But now all of a sudden you're going to put increased pressure on your inside medial elbow or your anterior front of your shoulder. So it's a mechanical block. And if you don't take care of the bottom half, you may ultimately have some issues in the top half. And I'll give you a great example history-wise. Nolan Ryan, granted he was 46, but he pitched 20 some years. He never had an elbow or shoulder injury. But in August of his last year, he had a rib cage strain, which was probably an internal oblique strain. A month later, he blew out his UCL. So again, 46, but never injury, had an internal, I'm assuming it was an internal oblique injury, returns to pitching a month later, blows out his UCL. So again, those are things we need to look at. And that's the things we look at our pitchers in our clinic is, look, you're coming for this, but more than likely something downstream is happening that's going to change your mechanics, put undue stress. So again, that's where I would go with Caleb at this point.
I think that's a great example talking about Ryan, because one, that's a guy who went 20 years between any type of injury issues. 20 years is a long time, by the way, when you think about it.
Yeah, exactly. Yeah.
And two, go ahead.
No, again, he was 46, but again, it seems kind of more than coincidental that you have an abdominal injury and then a month later you're blowing out UCL. It's just,
And the other thing I was going to bring up is, from my experience, one of the reasons why I went to Ivy Rehab Physical Therapy was because, I described the pain in one area, but then when I got the MRI, it was actually something different. So then I had to go in, and basically we were working so many other things around the neck area.
Right. Yeah.
But even though the neck area was the origin point of the injury.
Right. So again, we just had a study. We've just had 2 studies that were published in the last year that really looked at we had kids with shoulder issues, but there's shoulder and medial elbow injuries, and we're looking for the link from actually the cervical spine. So those kids may come in and not complain of neck issues, but when you go up top, you start finding that they're kind of lit up. So it's an amazing thing, but you can't just treat that symptom. If someone comes in with like an elbow problem, you can't just treat the elbow. Why is he having the elbow problem? And the abdominal, it's the link to the lower half to top half. And if we're not looking at the whole kinetic chain, you're going to be missing something. So, but yeah, it's an interesting one, but it's not uncommon. And again, the reoccurrence rate of those internal abdominal oblique injuries can be up to 12 to 15% somewhere down the road. So something to keep an eye on.
Talking with Vinny Ceasrine here from Ivy Rehab here on the Ivy Rehab Injury Report here on Hanging with Hennig on 97.3 ESPN. Let's flip it over to the Eagles now. Jonathan Greenard has missed the last 2 weeks of training camp. He's unavailable to play tonight and for the next 2 weeks, say the Eagles. Now, they are calling it a pectoral strain. And what's interesting to highlight about this is, one, this is a guy who had shoulder surgery several months ago.
Right.
So that's one factor. The other factor is he did this while weightlifting. And that's what I want to start with.
Yeah.
We hear all the time people sustaining pectoral injuries when they're weightlifting. So what is it about weight training, especially for athletes, that leads into these kind of injuries?
Right. Okay. So that's a good, well, we actually have one of our therapists who tore his pec lifting a couple of years ago. So again, what's going to typically happen is, first of all, it's usually in the age group of 20 to 40, athletic males. Females are very rare that they're going to tear their pec. So what usually happens, it's usually mostly related to bench press, can be related to flies. It's basically on the eccentric load of that bench press that's where it's going to be torn. And the reason is because when we do an eccentric or negative, the muscle's lengthening, you're able to put more stress through that muscle. So again, that's usually the mechanism of injury. We have had traumatic. We treated a professional quarterback years ago who was up in that 90-90 position, and he got hit and just drove his arm back, and then the pec got stretched and torn. But for the most part, they're usually going to cure weightlifting. And interesting enough, actually more, you would think sometimes maybe benching with dumbbells would be a little bit more dangerous, but usually more with the straight bar. And I think part of it is because two things. One is your arm is kind of locked in that position on the bar. And number two is you're able to push more weight with a straight bar than you are with two dumbbells. So it's that eccentric negative loading where you're overstressing the muscle can't withstand it. And then you now again, there's different grades, there's different strains, and there's different areas of the muscle group. So, and that's going to really determine how fast your rehab is. Now, they didn't say if he had a minor or moderate strain. I'm assuming it's a moderate because I was listening to Vic Fangio talking about that. He's, it doesn't sound like he's going to be doing anything during training camp. Right. So if that occurs, you're typically looking at about a moderate or a partial tear. You're looking at probably a 6 to 12 week time frame. And then heavy resistive training, you probably can't start. And again, I don't know the situation, but you usually can't start till around 8 to 10 weeks. So, and again, with his position, I mean, he's got to be able to move people, shed blocks. So it's going to be a little bit taxing, but again, you can get the tear. Typically, if you have a strain and it's in the muscle belly, those usually heal pretty quickly because you've got a good blood supply. The ones where the muscle turns into the tendon or just moves into the tendon, that's usually where your partial and tears are, and they're moderate tears. And then where the actual tendon inserts into the bone, that's usually, if that comes off, that's usually an avulsion fracture, and that's a grade 3, and then that's surgery, and then you're out, 3 to 4 months. I know J.J. Watt came back like 2.5 months after a pec major repair, but that's kind of on the fast end of returning. So JJ's
also a freak. So
yes, exactly. Yes. Slightly different. Yes. Yeah. There are some people that are genetic freaks. So it occurs, but probably in that 3 to 4 month time frame. They don't typically do surgeries for a partial tear. So this is probably just going to take some time and, hopefully be able to return.
So the other question I wanted to ask about this is because we've heard stories about sometimes athletes, when recovering from one injury, they train so hard that they neglect another part of the body. So not that we know this for sure, but I think it's an important question to have a conversation about is if someone is recovering from, let's say, a shoulder surgery or anything in the upper body region near the pectoral region, what is the IV rehab physical therapy approach that makes sure people don't sustain another injury on the way to recovery?
All right, so that's a very good point. So again, I tried to do some research and try to find out exactly what surgical procedure he had done, and I couldn't find anything. All I went back and I saw that their coach had said it was a routine procedure, and they really didn't specify. Now, I'm assuming he got injured earlier in the year, last year. He returned, and against the Cowboys, he sustained an injury. They had surgery. So I'm not 100% sure, but either way, whether he had a labral repair or a capsule repair or a cuff repair, it's probably not going to matter too much. Either way, the cuff would have been affected, the rotator cuff. So the rotator cuff works to stabilize the ball into the socket. Besides rotation and elevation and things like that, its main function is to keep the ball stabilized in that socket. So theoretically, if you're rehabbing from that and you're not 100% strong enough, then it's conceivable that when you're doing a resistive exercise, another muscle group is going to have to pick up that stability issue. And it's conceivable. I don't think there's necessarily a direct link. And again, I don't know what he had done previous to this. And again, I tried to do my due diligence on it, but I couldn't really find exactly what. But yeah, we see that all the time in the rehab facilities. You have an injury, it affects something else. I'll give you a typical one. If you have somebody who sprains their ankle and it's really swollen, there's a reflex that your glutes are going to get inhibited. So if I see somebody come in 2 weeks post ankle sprain, and I go up and check their glute strength, it's crap. So, but then again, if you don't address that, your glutes work to help stabilize your lower half when you're on one leg. If you don't address that, you're going to be more prone down the road to possibly rolling over your ankle. So yeah, everything is kind of linked, but without knowing what he had done, it'd be kind of hard to say. But I'm assuming there might be some kind of correlation to that. And again, if something like that, maybe if you're using dumbbells or you got something outside your peripheral vision and you can't, you lose that ability to stabilize or have that awareness of where your shoulder is in space, then your pec's got to fire maybe a little bit more to control it. So, I mean, again, it's always seems to me a little bit more than coincidental when it's the same side. So,
well, and I know it's not one and the same, but for example, when it came to my personal injury, I had affected my shoulder, my left shoulder, before my neck got messed up. And what happened was that, I was basically compensating for the shoulder, and then I fell, and then my neck got messed up. So it's one of those deals where it's like, if the one isn't there, sometimes the other can't happen, right?
Exactly. And again, without knowing, what he had done before, it's kind of hard to say, but either way, it's probably going to be, if they're calling it, if they're saying he's going to be out to training camp, I mean, it must have been a pretty substantial injury to his pec, but hopefully he'll be getting back as soon as possible.
He is Vinny Ceasrine. He is the let me get the title here. Clinical Director of IV Rehabilitation at Westfield is where he works out of, and he joined us here for this week's IV Rehab Injury Report here on Hanging with Hennig on 97.3 ESPN. And as I always say, they are best-in-class outpatient physical therapy, and I know personally because they were my physical therapists. Dr. Josh already put up with me for several months, so I can confirm that you guys do a great job. And Vinny, great stuff today. I appreciate you jumping on.
Okay. All right, man. Thanks a lot. Have a great weekend.